аз няма да се повтарям с това, което имахме по отношение на презентацията на професор Смисъл, но ще покажа и практически как се прави това в реалната практика. Искам да шерна виждате моята презентация. Така, какво представлява миокардния ворк за тези от вас и работата на миокарда, за тези от вас, които не бяха в практическата част. Това е нов начин на изобразяване на работата на сърцето по отношение на анализа на миокардната деформация. Стрейнът допълнително дава значителна информация по отношение на това какво се случва с фракцията на изтласкване, но новите методологии, които се наложиха последните години, дават значително по-добри прогностични стойности по отношение на подобряване на грижата на пациентите. И за тези от вас, които бяха присъствали тук по отношение на презентацията на професор Смисъл, той каза, че вече в Съединените щати изследването на стрейна се реимбурсира от тяхната здравна система, което наистина подобрява диагностиката, което стимулира всеки лекар да работи тази методология и да познава вътрешно по-детайлно необходимите неща, които трябва да презентира. Така че не само стрейнът, но и работата на миокарда по отношение на диагностиката ни дава допълнително възможности и ние трябва да ги използваме по отношение на оценката на наляганията, които се променят вътре в самата камера. Така че стрейнът е все пак показател, който се променя от преднатоварването и след натоварването. Именно налягането в лявата камера генерира тази енергия, тази сила, която определя контрактилитета на самия миокард. В зависимост от тази деформация, която ние измерваме с стрейн, отнесено във времето, но под различно напрежение, се получава именно тази ефективност на това съкращение, която ние целим да определим с този миокардна работа. И именно това е схемата, която се получава при анализът на стрейна под различно артериално налягане, така че артериалното налягане е измерено при нашите пациенти, е задължително да участва в тази оценка на работата на камерата и деформацията, която оценяваме. Кои са индексите, които ние използваме при този тип анализ? Това е глобален Work Index. Именно това е работата между затварянето на митралната клапа и отварянето на митралната клапа. Глобална конструктивна работа, това е цялата помпена функция, която се осъществява по време на целия съкратителен процес. Глобалната Global Wasted Work, това е за глобалната загубена енергия или работа по време на систола, удължаването, което се последва от скъсяване на камерата преди затварянето на аортната клапа и глобалната недостатъчност на работата, или това е коефициентът на работа на лявата камера. Global Work Efficiency. Това е фракцията на конструктивност, която дава също един анализ във вид на процент от 0 до 100%. Как се определят тези различни индекси по отношение на този сърдечен цикъл? Виждате началото, QRS комплекса отговаря на затварянето на митралната клапа, имаме времето на изоволометричната контракция, отварянето на аортната клапа, цялата систола с ежекшена, който определяме. Тук имаме времето на АТ-фосфатазата, консумацията на АТ-фосфатазата, оценката на левокамерната фракция, глобалният систолен лонгитудинален стрейн на върха на затварянето на аортната клапа, постсистолният лонгитудинален стрейн, миокардния ворк с Global Constructive Work, който също оценяваме. Следва затварянето на аортната клапа на края на Т-вълната. Имаме времето на изолонатичната релаксация, отварянето на митралната клапа, което се последва от диастолата с фазата на бързото пълнение, на диастаза и на предсърдното съкращение. Това е най-общо, което ние анализираме в този цялостен процес на един сърдечен цикъл на съкращение. Така че левокамерната механика намира своето приложение именно чрез оценката на този миокарден work. Клиничните приложения професор Смисът ги даде ясно. Това, което е задължително, един анализ, който изисква да имате 3 кухини от апикална позиция, 3 кухинен, 4 кухинен и 2 кухинен срез. Задължително да сте измерили артериалното налягане на нашия пациент, за да получите този bull eyes и съответно да преминете към скалата, която дава съответно напрежението и работата на миокарда. Можем да извадим и всичките тези криви, които ние видяхме като диаграми, които се получават заедно с тези показатели, с трейн, глобалната работа в нов метод на анализ на изразяване чрез милиметър живак за процент, конструктивната работа, глобалният work efficiency като процент на изразяване на тази енергия. Няма да се спирам върху тези проучвания, които са правени по отношение на пациенти с различни фази, от различни типове кардиомиопатия, дилатативна, рестриктивна и хипертрофична кардиомиопатия, в зависимост от наличието и на липсата на исхемия, също е провеждан този анализ, което също има ефект. Пациенти с ляв бедрен блок, когато имаме показания за ресинхронизираща терапия и подобряване на кривата на работа на миокарда, именно чрез подобряване, след като бъде преспейсиран добре ресинхронизиращият електрод по отношение на съкращението на септума, значително по-добре съкращение на септалната стена по отношение на латералната стена. Това е проучването НОРЕ, което също дава нормалните стойности при мъже и при жени в различните възрастови групи. Какво трябва да знаете, че при нормална стойност на артериалното налягане и пиков систолен лонгитудинален стрейн минус 21, очакваната стойност, която би трябвало да имаме, около 2520 мм на живак процент. Тогава коефициента на ефективност ще бъде близко до 100 и загубата на работа ще бъде близко до 0%. Това са стойностите, които са дадени, както осреднени за мъже и за жени, за тези 4 показателя, които ние изследваме. Естествено, след като това е механичен, все пак показател, който се получава след като бъдат извлечени различните криви на анализ на съкращението на миокарда, той все още има и своите недостатъци, тъй като все още не е лимитиран като за ежедневна употреба в клиничната практика, но все пак предстоят нови проучвания, които ще валидират именно този показател и ще дадат възможности да използваме в клиничната практика. И нашият опит в Национална кардиологична болница, заедно с няколко колеги, допълнително ние наблюдавахме при пациенти с артериална хипертония, с левокамерна и без левокамерна хипертрофия, какво се случва, заедно с провеждането на един стрес тест с хандгрип, с силометър, който да определи какво е напрежението, което се извършва по време на един изолометричен стрес тест, който се провежда по този начин. И оценката на левокамерната хипертрофия дали ще повлияе върху тази миокардна работа. Естествено, при пациентите с артериална хипертония, левокамерна хипертрофия, при нормално артериално налягане се получава увеличаване на левокамерния стифнес и на регионалната миокардна работа, която се определя от повишеното преднатоварване съответно. Това са други проучвания също от групата на професор Донал, които изследват както при здрави пациенти, така и при пациенти с левокамерна фиброза, хипертрофична кардиомиопатия. По време на стрес, това беше показано и от професор Смисът, тъй като това са тяхно проучване, тяхна разработка, те са едни от пионерите на това проучване. И като една обща схема, това, което трябва да запомните, за да анализирате този метод да го използвате в практиката, трябва да имате първо измерено артериално налягане на вашия пациент, трябва да имате ехокардиографския образ, който трябва да бъде съответно вързан с ЕКГ и да имате тези 3 изображения от апикална позиция, за да получите булайса, който имате, и след това да интерпретирате тези криви, които са на очаквано налягане и на измерено налягане, и да се определи вече времето на очакваната работа, която ще се извършва от миокарда, и тази работа, която ние сме анализирали като извършваща се в момента. Благодаря ви за вниманието. Мисля, че може би по-интересно ще ви бъде да покажа това как се прави в реалната практика. Отварям ехопака. Мисля, че този, който е пациент номер 5. Ще започна с този образ, който е 10. Значително добро съкращение. Да. Започваме пак от начина, по който анализираме. 2 дена с спекъл тракинг, Q анализис, VD стрейн, аплакс за апикална позиция, базално, по часовниковата стрелка, бордираме. Процесинг. Мисля, че сме добре с затварянето на ортната клапа като тайминг. Глобалният стрейн от трикохини, казахме, е минус 20%. Следващият образ, който ще извикам, това е 4-кохинния стрейн, 4-кохинен образ. Пак 2D стрейн. Колеги, когато имате възможност, използвайте включително и да работите тези методики, защото това е бъдещето. Това дава допълнителна информация по отношение на вашия пациент. Това, което ви показах, че можете да използвате дори автоматичният анализ, а не да губите толкова време, той е възможен включително и на тук на самият ехопак да се направи. Но аз ви показвам това, за да го запомните откъде да се почне този анализ и да го спазвате като ред, защото е важно в вашата практика. Така, това е трикохинния срез. За момент. Само, че това ми го разчете като аплакс. Аз ще се върна да го разчета отново. И това, което имаме като стрейн е минус 16%. Съответно, layer стрейна можем да покажем, който е тук при нашия пациент. Съответно, нарушенията, които са с предносепталната стена. Това е един исхемичен пациент. И работата на миокарда, която се извиква пак от менюто, и съответно да вкараме стойност на артериалното налягане. Предлагам да сложим 135 на 85. Глобалният стрейн е минус 16. Съответно, глобалната работа като индекс е 1576 и коефициентът на ефективност е 97%. Все пак виждате, този показател дава допълнително възможности да анализираме тук като процент на ефективност. Виждате кои сегменти са най-засегнати. Именно тук в тези латерални базални сегменти имаме най-ниските стойности, които показват, че тук имаме доста по-неефективна контракция в този случай. И кривата, която ние сме направили в червено, ни показва каква е конструктивната работа, загубата на енергия, която е съвсем малък процент, и тази крива, която се доближава до това, което се прави в реалната практика. Така, желаете ли още веднъж да го направим това или да преминем към лекционната част? Към лекционната част, добре. Аз ще поканя тогава професор Кинова, защото тя е чермен на следващата сесия заедно с мен. Моята лекция вече мина почти с практическо показване. Нашият следващ лектор е професор Вандер Брюне, който ще говори за оценка на асинхронност с помощта на спекъл тракинг ехокардиографията, тъй като ние вече сме в последната сесия, която ще покаже новостите и най-новите тенденции по отношение на миокардните деформации в ежедневната практика.
Good afternoon, everyone. First of all, I would like to thank the organizing committee and especially Professor Irisova for the kind invitation to join everyone here on this amazing ECHO Congress. And I really wish I could be there, but unfortunately, it'll have to be next year. If anyone is ever in Leuven, please let me know. I will kindly show you around and show you the nice city of Leuven as well. So the purpose of this lecture is to improve the understanding of the physiology of cardiac desynchrony, and I'll focus a little bit on electrical versus mechanical desynchrony, and if there's mechanical desynchrony that's related to electrical conduction abnormalities, or mechanical desynchrony that's related to dispersion and ventricular inefficiency. I hope with the lecture also to improve understanding how cardiac resynchronization therapy can improve cardiac mechanics, eventually leading to reverse remodeling of the ventricle. And obviously, as it's the purpose of the talk, which echocardiographic modalities can be used to assess different components of desynchrony. If we talk about the pathophysiology of desynchrony, I think it's important to distinguish between electrical desynchrony, which is the prolonged inhomogeneous electrical activation of the myocardium, as we see in patients with bundle branch block, left bundle branch block, right bundle branch block, and which is diagnosed on surface ECG, and the mechanical desynchrony, which is observed on imaging assessment. And then we can distinguish, as I will discuss later, between atrioventricular desynchrony, interventricular desynchrony, intraventricular desynchrony. And again, and I'll come back to this later, again, distinguish between mechanical desynchrony that is related to electrical conduction delay, or mechanical desynchrony that is related to a dispersed mechanical contraction in dysfunctional ventricles. To explain the pathophysiology of desynchrony, I refer to this very elegant paper of Fritz Prinsen, but I think the prototype of electrical and mechanical desynchrony is a patient who has a dilated left ventricle with a reduced ejection fraction and a left bundle branch block and a QRS duration of more than 150 milliseconds. And as you can see here on the left side of the slide, this results in early left ventricular septal activation and late lateral wall activation, causing a poorly coordinated LV contraction. And this poorly coordinated LV contraction will subsequently result in differences in regional myocardial workload, differences in wall stress, differences in blood flow, even differences in blood consumption within the ventricle, and even differences in glucose metabolism. And all this will eventually cause myocardial remodeling. If we look And imagine this is an apical 4-chamber view. And if you look at the strain curve of the septum and the strain curve of the lateral wall in this poorly coordinated LV contraction, we see that there is early septal activation causing some form of septal flash. And this is important to realize during isophonomic contraction of the left ventricle. So there's already deformation of the septum, pre-stretch of the left ventricular lateral wall. Then there is late lateral wall contraction. This interrupts the contraction of the septum. We see septal rebound stretch. So this is not contributing to shortening in systole anymore. And we see also post-systolic shortening of the left ventricular lateral wall. All this causing dysynchrony, wasted work, inefficiency of the left ventricle. And the purpose of CRT obviously is to correct this. We have the right ventricular lead, we have the left ventricular lead. We see that the activation within the ventricle is much more coordinated. If we look at the strain curves, again, we observe the same thing. We see that the septum and the left ventricular lateral wall now are contracting synchronously, resulting in improved efficiency of the ventricle. So if we correct this electrical activation, we improve septal lateral wall activation, and this will subsequently improve stroke volume, cardiac output, but also force development at unchanged filling pressures. Again, this will result in reverse ventricular remodeling, and as we know from the clinical studies, result in improved outcome for our patient, and that's obviously the purpose of CRT device in the first place. If we look at the ventricle, there is sinoatrial activation, there is conduction through the atrioventricular node, then there's very rapid activation through the hysprokineous system, causing a delay between both ventricles of about 70 milliseconds, which is very close. If we add to that 30 milliseconds for calcium influx and binding from the sarcoplasmatic reticulum secondary to depolarization, we know more or less the delay between electrical activation and mechanical contraction that is occurring in a normal heart. Obviously, if there is dysynchrony, there will be AV dysynchrony, interventricular dysynchrony, intraventricular dysynchrony. And the purpose of our examination or our echocardiographic assessment is to be able to distinguish between dysynchrony that's related to electrical conduction abnormalities, which we can correct with CRT, and dysynchrony that's related to a dispersed mechanical contraction in dysfunctional ventricles, which obviously we cannot correct with cardiac resynchronization therapy. I know it's not per se the topic of this talk, but just for the sake of being complete, atrioventricular synchrony is obviously important, and an optimal AV delay should allow for completion of atrial contribution to diastolic ventricular filling in order to optimize ventricular preload. If we look at the pulsed wave mitral valve inflow, we see nice E early filling and A late filling or atrial contraction separation. And the A wave, which is symmetrical, should usually terminate 40 milliseconds before QRS onset and or mitral clip. If the AV delay is too short, we'll notice that the A wave is truncated, that filling is prematurely terminated. If the AV delay is too long, we will observe diastolic AV or mitral valve regurgitation because there's ventricular contraction before termination of atrial contraction. So atrioventricular dysynchrony is very easily assessed by using pulsed wave Doppler and a surface ECG on our echocardiography. This is a patient with a complete AV block, just indicating what the consequence could be of AV dysynchrony. This was an older patient with complex congenital heart disease, but he had AV block, and the question was, should we synchronize between atria and ventricles? This is before AV sequential pacing, and we can see that these atrial contraction, these A waves, cause diastolic pressures up to 40 millimeters mercury, which is obviously not insignificant. And if we then pace the patients, we saw two things. One, the atrial waves disappeared, which is good, but there was also an improvement of the systolic aortic pressures, indicating that hemodynamic efficiency improved with improving atrioventricular synchrony. Secondly, what we can assess using echocardiography is interventricular desynchrony, which is the delay in activation and contraction of the left ventricle and the right ventricle, which we can measure by measuring the delay in onset of LV and RV ejection using pulse wave Doppler very easily, or using tissue Doppler imaging, measuring the delay in onset of LV and RV contraction. Excuse me. If this delay is larger than 40 milliseconds, this is considered abnormal. Again, this is an example. We have the onset of the QRS. We have the onset of RV ejection, which is 100 milliseconds. Here we have a delay of 160 milliseconds between the onset of the QRS and the onset of LV ejection, suggesting interventricular desynchrony in this patient. But what we're all here for is to assess intraventricular desynchrony, where the fundamental problem is that different and oftentimes opposing segments are contracting while others are lengthening in the same ventricle at the same time, causing inefficiency in this ventricle. And I think it's important to know that if we're looking for this type of electromechanical desynchrony, that we don't necessarily need the most advanced techniques. This is a parasternal long axis view with an M mode. Through it, we see the septum, we see the posterior wall of the left ventricle, and I think we see the ECG, which is obviously important for timing, and we see a septal flash, septal rebound stretch, and late lateral wall contraction, probably with some post-systolic shortening, which I cannot be sure to show on this image. The septal flash, as explained before, indicates early septal activation and deformation during isophthalmic contraction, whereas the septal rebound stretch indicates and the movement of the left ventricular posterior wall indicates late activation of the LV posterolateral wall, abrogating also septal contraction. So just by using M mode and a good parasternal long axis view, we can already go a long way. This is apical rocking. So this desynchrony will show itself on the screen by something that's called apical rocking. It's very nice work from Professor Vogt here at the department in UZ Leuven, who spent quite some time and did some fantastic research validating this finding. But this is just a case of a patient with a left bundle branch block and very typical left ventricular desynchrony. And as you can see, early septal activation pulls the apex towards the septum, whilst late lateral wall contraction pulls the apex laterally during injection, causing a very typical pattern of apical rocking, which integrates the findings that I theoretically explained in the previous slides. This can be evaluated quite easily on an apical 4-chamber view and does matter. This is very nice work from Ivan Stankovic when he was in Leuven working with Professor Vogt, indicating that absence of apical rocking was related to a less favorable outcome after cardiac resynchronization therapy in a large cohort of CRT patients. When going from grayscale to deformation imaging, I think the advantage or the attraction of deformation imaging to assess the synchrony is that we can actually perform multiple measurements in multiple cardiac segments during the same cardiac cycle at a high frame rate, in order to assess the intraventricular desynchrony. There has been a whole abundance of literature assessing different desynchrony parameters, but usually these parameters measure time delay from onset of QRS to peak velocity, peak strain, a combination of different segments, standard deviation, or absolute values. And I've put a summary, and I refer to this paper of Dr. Meli and Dr. Ferrari's not quite recently published, summarizing all these desynchrony parameters. But unfortunately, the Prospect study, which was published in 2008 in Circulation, has learned us that actually the predictive value to predict CRT response of all these parameters was quite low. And the reason why I think largely or partly, at least partly, reflects the I would say the imperfection of these parameters, of these time to peak parameters in assessing the synchrony. This is a very elegant study. This is simulation work from Joost Lummens, where he simulated progressively delayed onset of the LV free wall activation, where you can see here the strain curve that would be observed in the septum, and the strain curve that would be observed in the lateral wall, and the changes as your activation and contraction is delayed. And as you can, if we only look at the peak values, we can see that, for example, here when we go from 40 milliseconds to 60 milliseconds, the peak actually changes. So if we evaluate time to peak parameters, we get clusters of data, and not a continuous relationship with response to CRT, which is probably one of the issues when using these parameters in the clinical field. If we use other parameters such as the septal flash, septal rebound stretch, which actually implement the pathophysiology of the synchrony into the parameter, apical rocking is the same thing, we see that there is a continuous relationship with CRT response, a continuous relationship with the delta or the change in LV and systolic volume that is observed in these simulation models. So I think important from this lecture is that you really understand the concept and the pathophysiology of the synchrony, and how we will assess this, using different echocardiography parameters. And can we use deformation imaging? Obviously, if you look at the strain curves, if we look at the strain curves of the left ventricle and we take two opposing walls, I think what we should look for is a typical classic pattern, deformation pattern that is suggestive of electromechanical desynchrony, where we see early septal activation and concomitant lateral wall pre-stretch, as we can see here, and then late lateral wall contraction and abrogation of septal contraction, as we see here. So this is so-called classic pattern desynchrony that we can observe using deformation imaging. So I would say that it's very important to look at the image, to look at the strain curves, to try to interpret these strain curves and see whether we are faced with classic pattern desynchrony or something completely else. I won't go into too much detail here, because this is very elegant work and excellent work done by the previous presenter, Dr. Smithett, evaluating pressure strain loops to estimate regional segmental work, to estimate constructive work, to estimate wasted work, and this has been implemented on the GE machines just by combining ventricular pressures, which can be obtained invasively or non-invasively with parameters of deformation imaging. And this is the idea, and I have to thank again Jürgen Duchenne for kindly providing me these slides. This is a patient with clear left bundle branch block, typical apical rocking, early septal activation with septal flash and late lateral wall activation, causing the typical rocking motion. And if we evaluate the pressure strain loops, then we see that there's lots of wasted work here at the level of the septum, and we see a different curve in the lateral wall, and obviously this is related to remodeling, to progressive remodel, as already explained, of this left ventricle. And the question that Professor Vogt and Jürgen asked here, whether changes that are observed acutely after implanting a CRT device would actually predict remodeling after CRT implantation. So if we actually synchronize the ventricle and we observe a positive response, if we can predict somehow this remodeling. And I think the results were kind. There was a group of patients where we observed the least reverse remodeling, and that was the group where we saw the least change in work. And if we look at the group where there was most reverse remodeling, we saw the largest change in work. So it was interesting to observe that in patients where we had the largest difference in lateral to work septal difference, those patients had the most optimal remodeling observed after 1 year. I think deformation imaging can also be used to provide or to determine the optimal LV pacing site. And this is a very nice paper published a few years ago in JACC Heart Failure, where they compare responders to non-responders based on the fact whether the LV lead was placed on the close or remote from the echocardiographically determined optimal LV pacing site. And the optimal LV pacing site was determined as the segment with the longest time to peak strain, but also the site with still preserved strain, in order not to identify a location with scar. And if that was the case, the responders were more likely to have a pacing site that was concordant to the optimal LV pacing site, whereas the non-responders were more likely to have a remote location as determined by the echocardiographically determined optimal LV pacing site. This is again data from Jürgen Duchenne and Professor Vogt here, where they asked the question whether echocardiography would be enough to account for scar when assessing patients for CRT, and this is in just over 200 CRT candidates, where they had CMR and determined the numbers of segments with more than 50% late gadolinium enhancement to determine scar. And they also had echo, and aside from septal flash and apical rocking, they also determined scar and volumes. And then they looked 1 year later, where they defined a responder as someone who had more than 50% decrease in end-systolic volume after CRT implantation. Septal flash and apical rocking on itself did well and predicted CRT response quite well. But if visual assessment of scar was implemented, the area under the curve significantly improved, but CMR did not provide any additional value in determining CRT response in this interesting study. And just as a congenital cardiologist, I think it's of interest to indicate that there's also such a thing as dysynchrony in patients with tetralogy of Fallot in the right ventricle, where we observe some kind of mirror image of a typical LBB-induced dysynchrony, where you see in the right ventricle apical wall, apical septal pre-stretch with late lateral wall contraction and post-systolic shortening. And Dr. Friedberg, Bart Bijnens, and the group in Toronto provided excellent work suggesting that this type of right bundle branch block dysynchrony observed and identified using deformation myocardial imaging was associated with RV remodeling and dysfunction, and could be even of more importance than the presence and degree of pulmonary regurgitation in these patients after tetralogy of Fallot repair. So to conclude, electromechanical dysynchrony refers to incoordinate contraction relaxation between opposing walls that results from electrical conduction delay. When we do deformation imaging in these patients, we should look for a classic mechanical pattern that can be recognized by various echocardiography modalities, by IM-mode, by just looking at an apical four-chamber view, but also using deformation myocardial imaging. But we should distinguish this from mechanical dispersion, not resulting from electromechanical dysynchrony that is associated with ventricular inefficiency and may be related to poor outcome, but is unlikely to respond to CRT. Deformation imaging with newer tools such as stroke work provide useful additional information in the assessment of dysynchrony, and imaging may have a place for optimal LV lead placement as well. I'd like to thank the team in Leuven, the whole congenital team, as you can see here, but also Professor Voigt, who's the head of our imaging department, and Jürgen Duchenne, who's working with Professor Voigt, who also kindly provided some of the images and videos that I used in this talk. Thank you.
Thank you, Professor Van de Bruin, for your nice presentation. I would like to ask you if you use radio strain when assessing interventricular dysynchrony in your patients, because not every cardiologist have other forms of echo software to calculate myocardial work index or something.
Mm-hmm. Thank you for the very kind question. Thank you again for the invitation, Krasimira, as well for being here. I wish I could be there in person, but unfortunately, just being here in Leuven. So, with regards to the question whether I use deformation to assess the synchrony, yes, but I obviously yes. There's obviously in our center a lot of attention to just apical rocking, and that's just related to the work that my colleague Professor Vogt is doing within the synchrony, just evaluating the rocking motion of the heart, evaluating septal flash. But we still do use deformation imaging to go and look for that classic pattern of electromechanical desynchrony. What we did abandon a little bit is the earlier parameters, where we use time to peak values and standard deviation in different segments to calculate the synchrony indices, because the prospect study was a bit disappointing. But we do use deformation imaging, but we integrate the findings that we see, the curves that we observe to evaluate the synchrony. Obviously, if you're so lucky, as Professor Hristova indicated, to have myocardial work in your GE machine, that is fantastic. But in Belgium as well, most of cardiologists don't have this option yet. So then we use classic deformation.
Thank you.
Други колеги, въпроси към професор Ван дер Бруне? Thank you, Alex, for the very intelligent presentation, really, because we are further on the timing. I would like to thank you once again for your contribution. Many greetings for all my friends in Leuven.
I absolutely will. Please come over soon. We miss you here.
Yes, everything has changed last year, but I hope that we will meet very soon here in Bulgaria also.
Absolutely.
Okay. Thank you so much. And we will continue with our next presenter. This is Professor Filip Lunkaric. He is working together with Professor Bart Bienens. He is also from Leuven Group from Myocardial Deformation Imaging. Професор Лункарич работи в момента в Барселона заедно с професор фон Бандер Биденс, който е един от пионерите в Artificial Intelligence, изкуствения интелигент по отношение оценката на лявата камера. Това е нашата последна лекция от лекционната част тази програма, тази вечер, но ние ще продължим само след лекцията с вечеря и ще се върнем обратно тук, за да поседим най-интересната част от клиничните случаи на колегите, които ще бъдат презентирани тази вечер. Така, професор Лункарич, the stage is yours.
Hi, thank you for the introduction. Although I'm not a professor, it sounds very good. Anyways, I'm very pleased to be presenting our work here in the name of our group and to share our experience in phenotyping using multimodality imaging and machine learning. Now, to really tell you something ahead before we start about our project, it's Marie Curie European project led by Pablo Amata at King's College, and the goal is to create new tools, computer and machine learning tools, to really try to develop patient-tailored medicine and cardiology. And we have a huge group with different centers around Europe, industry, academic and medical centers, which I was positioned in Barcelona for 3 years, working with Marta Sitges and Bart Bienens. And there are two mentors that are actually, one is a clinician and one is an engineer. And that's an important point because the main goal of our project was actually to try to tackle these huge barriers between engineers and cardiologists, where we both have the same goals in developing patient-tailored medicine. Now, when we say patient-tailored medicine, we basically talk about something we do every day in the clinical office, we try to collect as much data as possible about a patient, integrate it, and then phenotype the patient based on this data to try to relate the patient to a certain part of the spectrum of a cardiac disease. Now, this is relatively tricky itself, but the biggest challenge is in the next step, trying to relate a position in the disease spectrum to certain clinical risk, so we can define a medical treatment for the patient at hand. Now, obviously, in every one of these steps, we have different targets for artificial intelligence, and especially so if we consider cardiac imaging, there's so many steps where we can really try to enhance the workflow and save time and improve the efficiency of our work in the hospital. Now, artificial intelligence is a really popular term and everybody speaks about it. So let's try to see what it actually is. Saying it simple, it's basically trying to create algorithms or computer programs that perform tasks usually attributed to human intelligence. And these tasks are, for example, solving problems or recognizing patterns in data. In medicine, we can roughly try to separate them into different fields, for example, natural language processing or speech recognition, which try to translate the communication of humans and computers, for example, the patient-doctor communication, to try to digitalize it in real time or to try to assess risk from written records. We have computer vision, which tries to translate real-life images into a language that a computer understands. We have robotics, which tries to construct physical intelligent systems, which can help with surgery. And then we have machine learning, which is basically part of any artificial intelligence. And you can imagine it to be the tool with which we achieve artificial intelligence. And don't worry, this talk isn't really about going into specifics of the technical side, because we're clinicians and we can't really bother to learn all the details. However, I'm just going to say that we can roughly separate machine learning into supervised learning, where we usually try to predict an outcome, and supervised learning, where we usually try to find patterns in medical data, and deep learning, where we usually try to segment medical images, for example, in CMR, segment the volumes automatically. So with this in mind, let's look at a few examples that our group did this past few years. And we'll start with an application where we try to integrate data from very heavy data sets with machine learning to try to find new knowledge in our clinical data. So when we integrate data in the clinical sense, well, we usually start with standard stuff. For example, the gender, the age, comorbidities, the genetic status, if we're talking about LV hypertrophy, for example. And then we move on to invasive imaging, usually the cheapest and the most accessible one, echocardiography, where we look at structural changes. And then we look at function, for example, Dopplers, speckle tracking, or such. When we try to integrate all the data together, we can already try to position a patient in a spectrum of disease or a spectrum of remodeling, where it's relatively easy to find really healthy hearts or really remodeled hearts. However, the clinical gray zone can often have overlapping findings, which can be tricky and hard to interpret. For example, in LV hypertrophy, we have this finding of basal septal hypertrophy that we see actually very often in both hypertension and HCM. However, etiology-wise, it's very different. In hypertension, it's a consequence of heterogeneous loading and wall stress distribution, whereas in HCM, it's a consequence of genetic heterogeneity and tissue remodeling. Now, it's very important to tell them apart, obviously, as the risk of sudden cardiac death, the clinical management, the way we treat the family. And we usually tell them apart by trying to use non-invasive imaging, looking at the type of hypertrophy, distribution of fibrosis, the different severities of obstruction or dysfunction, and of course, deformation imaging. Now, I'm going to show the differences in deformation phenotypes between these two diseases in the next slides. However, the question is, why does this happen? How can we relate different deformation phenotypes to underlying cardiac microstructure? Well, with histology, we can see 2D images, so it can be really tricky. However, with new imaging modalities such as synchrotron imaging, we can get high-resolution images and reconstruct 3D collagen microstructure or vasculature that corresponds to the patient's real microstructure. A synchrotron, just in short, is basically a source of X-rays like a CT, but of very high quality, For now, they're very hard to reach and only research, but in the future, there's predictions that can be tabletop synchrotron devices, which can be used for analyzing biopsies in hospitals. So let's see how our project can put this into use. We decided to look at patients with obstructive LV hypertrophy undergoing septal myectomies. We analyzed these patients' medical history and genetic data. We imaged them with echocardiography and cardiac magnetic resonance. And then the patients underwent surgical myectomy. This is open heart surgery to remove the tissue, of course. Then the tissue is collected and imaged at the synchrotron facility. This gives us a very multi-scale, multi-modality imaging protocol to really look at the heart in very, very different scales and try to relate what we can see non-invasively with what we can see on the microstructural level. And this, the pilot results were recently published in Frontiers of Cardiovascular Medicine. And I'm just going to show two examples here of a patient with hypertension and LV hypertrophy and a patient with HCM of a genetic type. What we can see on the CMR image of late gadolinium enhancement and hypertension is that we don't really have any typical signs of HCM in the contrast. However, in HCM, we can see these typical RV insertion point enhancement points and also some mid-myocardium LG enhancement. If we look at the deformation using speckle tracking, in hypertension, we can see that the basal septum is deforming rather normally, but with a reduced peak value. And as we go up towards the midsection, marked with pink here, we can see a similar pattern of deformation. And then as we go towards the apex, we can see improving deformation. However, on the other side, if we look at the deformation, we can see that the basal septum seems to be deforming again, reduced but normally. But as we go towards the midsection, we can see there's virtually no deformation at all. And then again, relatively normal deformation towards the apex. So what we can see is two very different types, very different phenotypes of deformation. And the question is, why does this happen? Well, if we look at our synchrotron images in the next slide over here, we can see a scan through the tissue with each image being 0.65 micrometers between image section, stitched together in a video going from the up of the tissue to the bottom of the tissue. So what we see in hypertension is that the myocytes are relatively normally oriented, but in HCM, it's obviously a very disorganized myocardial myocyte organization. What we also see is that in each patient, there's actually a lot of interstitial fibrosis in both cases. And we can try to say, okay, if we try to segment and follow these fibrotic regions, we can reconstruct the 3D image by stitching all of the segmentations of fibrosis. However, doing this by hand would be a nightmare, and it would take probably around a month to do. And this is where machine learning kicks in. We can use supervised machine learning to classify the pixels automatically into different tissue types and have an automated segmentation in a matter of seconds. And this is what we did. We segmented collagen and all of these patient images, which are more than 2,000 images per section. So we can reconstruct the 3D cardiac microstructure representation of collagen. So these are real reconstructions of collagen in each of the patients. And what we see are dramatic differences where both patients obviously have a lot of fibrosis as expected. And then when we look at the organization, we can see sheetlets of fibrosis in an organized fashion in hypertension, however, totally chaotic organization in HCM. So here in this example, machine learning can help us extract and visualize the myocardium in a novel way, which can help us better understand why we see non-invasive deformation phenotypes at the other hand of our imaging spectrum. Moving on to the next example, also related to LV hypertrophy, we wanted to see if machine learning can help us phenotype arterial hypertension by using only echo images, which are much more common in everyday clinical practice. Now, if we want to extract data from echo images, we can focus on structure, for example, looking at cardiac dimensions, cardiac volumes and areas, and we can focus on function, looking at blood flow Dopplers of the mitral inflow, the aortic outflow. We can look at tissue Doppler of the mitral annulus, and we can look at deformation curves using speckle tracking. Now, all of these curves, when you consider them, you can see that all of these velocity and deformation curves actually have a lot of information within them. And that if we look at them together, they represent different patterns in different cardiac pathologies. Now, this is something we know from clinical textbooks, from clinical experience, but the question is, can machine learning help us automate recognition of these patterns? Well, if we take a step back and say, how do we actually explore patterns in classical clinical data? Well, imagine two patients of similar age and systolic blood pressure. We can say they have relatively similar risk. However, if we add more information, such as body mass index, we may see that they're actually different. So adding more data actually helps us better phenotype the patient. That's clear to everybody. But what happens when we have very complex data? For example, tissue Doppler curve, which in every time point of the cardiac cycle has a different data point, giving an immense amount of information, which we can hardly analyze. Well, this is where machine learning kicks in again. Machine learning can help us reduce the dimensionality of the data, which basically means simplify the amount of data we have and visualize patients in a machine learning output space, a low dimensional output space where patients are positioned based on the similarity of integrated whole cardiac cycle data. In such a space, it's very important to understand why certain is in a certain part, and we can do this by analyzing characteristics of different regions. So this is what we did using unsupervised machine learning. We investigated if unsupervised machine learning can help us explore the spectrum of LV hypertrophy. To do this, we looked at hypertensive patients, healthy controls, HCM patients, and individuals with a family history of HCM. We use data that I just showed on the slide earlier, deformation data and velocity data, prepared it for machine learning, and then use the other clinical data for validation of our phenotypes. We then created a patient output space where patients were positioned in a common space based on the similarities of their integrated whole cardiac cycle data, and then used regression methods to actually understand the characteristics of patients in different regions. After this, we use clustering, which I'll tell you about in the next slide, to recognize different types of patient and interpret the patient phenotypes. So this may look like a lot, but let's see what this actually means by looking at the hypertensive patients. In a recently accepted paper in JACE, we showed that we can use machine learning to recognize patterns in hypertension. And what you see in front of you is basically output space created using machine learning, where patients are positioned based on similarity of their functional echo data. Now, the question here is, why are some patients here and why are others here? Well, to do this, we can really explore our output space, for example, looking at dimension 3, and try to understand what the characteristics of patients' upper part are compared to the patients on the lower part of dimension 3. And to simplify this, we can look at our 3D space from one side and get a 2D representation of the space, where we can simply compare patients in this region to patients in the bottom region. Just to go through it really fast, we can compare the average deformation curves in the two regions and see that, for example, patients in the lower part have reduced aortic peak velocities, have altered septal tissue Doppler velocities, reduced LS strain, and altered basal septal strain in the left ventricle with post-systolic shortening. We can then explore the clinical characteristics and see that they correspond to the functional characteristics, and conclude that the third dimension in our output space separates patients based on remodeling of the left ventricle and left atrium. We can do the same for the second dimension and see that it separates patients in this fashion based on heart rate, mitral inflow fusion, and structural and functional remodeling of another type. And then in the third dimension, we can see how it separates based on timing of cardiac events. Now, again, seems very complicated, but this is just to show you that we can really interpret our output space by exploring patient characteristics. The next step is much more understandable, and that's clustering, which is basically a machine learning technique which recognizes patients in our output space based on similarities and creates separate clusters or phenogroups based on these similarities. In our hypertensive space, we could see that our algorithm separates patients into 4 phenogroups, of which phenogroup 1 and phenogroup 2 were related to relatively normal function and hypertension, whereas phenogroup 3 was related to more severe systolic and diastolic impairment, and phenogroup 4 was related to a specific subset of patients, female patients with burden of comorbidities. So we can see we can separate these hypertensive patients into phenogroups based only on functional echo data in an automated way. But can we really trust this? Well, let's see if we project healthy patients into our hypertensive space. You can see that the healthy patients are in fact all projected and added using the same echo information from healthy patients, and they all end up in phenogroup 1 and phenogroup 2, validating that indeed these two phenogroups are related to normal function and hypertension. Now, obviously, this worked for hypertension relatively nicely. We were happy with this, but let's see what happens if we have HCM. Can we separate HCM and relatives? Well, this was really interesting, where we saw that in the red region over here, patients were had really severe structural and functional remodeling related to LVOT obstruction, whereas most of the genotype positive, phenotype negative relatives were positioned in this transitional region. So that's also interesting. But what happens when we put everybody together in the same output space? In this HCM and HCM relative output space, we added healthy patients and hypertensive patients. And what you start to really recognize is a spectrum of cardiac remodeling, where we see healthy phenotypes on one side, transitional hypertensive phenotypes in the middle, and then severe HCM remodeling on the right. Now, the obvious next step was to say, okay, these are echo-based phenotypes. Can we really trust echo-based phenotypes as really related to structure since they're function-based? Well, we looked at cardiac magnetic resonance late gadolinium enhancement and saw that the positive or red region of late gadolinium enhancement overlapped perfectly with our functionally severe remodeling phenotypes. So that, in fact, makes a lot of sense and really builds confidence that our machine learning can separate patients solely on Doppler and velocity values into clinically sensible phenogroups. Now, we're currently working, and we recently accepted to the ESC Congress this year with a multi-center study looking at HCM patients and relatives, but looking to separate different phenogroups of patients with severe remodeling, with severe outcomes. And we saw that indeed our machine learning could separate systolic and diastolic function, family history of sudden cardiac death, personal history of arrhythmia, and ICD implantations, really based only on very vague echo-based data and clinical variables that are accessible at all times. So we can see that machine learning can potentially help us phenotype patients. So how would this work in the clinical sense, in the clinical context? Well, let's take a look at these two patients. They have similar phenotypes. They have some hypertrophy, right? When we look at their deformation patterns, okay, we see a very big difference there. We look at their functional Doppler, we see a very big difference. If we look at myocardial work, which Professor Kristova just demonstrated, we see a huge difference. If we look at their microstructure, we see a huge difference. So what we want to say is machine learning can help us integrate the things we have available in the clinical work, which we can validate in a few patients using very novel technology. Now, going back to our slide here and saying, can machine learning help us classify these patients in a spectrum of disease? Well, let's take a look. This is our spectrum. This is our machine learning output space that we were just looking at. And the patients with a relatively healthy heart are indeed in the healthy part of the spectrum. The one with extreme remodeling is in the disease part. And then we can see that the two intermediate patients are actually positioned in different places in our output space. And the position they're in can really help us understand and better interpret the information we have from echocardiography. And in the end, how we can really try to use this technology? Well, if we have a clinical workflow in an echo lab where patients come, are imaged with echo, and then assessed for remodeling to decide on an intervention and follow-up, if we have a machine learning output space, which is created on a big amount of data, any new patient that comes in, we can see where he is positioned in well-defined output space. And based on his position, we can help, get information which can help us aid on making a decision, help us assess risk, and help us decide on the frequency of follow-up. So this was a very fast overview of how we can use machine learning for phenotyping. And in the last few slides, I'll show you the final frontier for machine learning, and that's not only positioning a patient in the disease spectrum, but also assessing risk. And we did this by looking at the ERIC general population study, the HEFREF study from MEDIT CRT, and the HEFPEF study from TopCat, looking at somewhere around 2,700 patients. And here we use similar machine learning input with deformation curves, volume curves, demographic data, some cardiac comorbidities, some ECG and blood pressure data, and some echo measurements. Our endpoint was death or heart failure hospitalization, and we performed the same machine learning I just showed. When we looked at the ERIC general population, you can already see that the mainstay of the general population is in one place, but there's this huge tail of unusual patients. When we add the TopCat study into our output space, we see they're in this unusual tail area, and the MEDIT CRT patients are also somewhere around here. Now, if we look at our output space from above to get a 2D representation, we can see a very nice separation in these three cohorts and actually calculate and create a heat map to calculate clinical risk. Furthermore, we can do clustering to separate patients into based on similarity of all their clinical data. And what we start to see is that we get three clusters with mixed populations, where cluster 1 is related to the lowest event rate, and cluster 3, green here, is related to a very high event rate. But what becomes even more interesting is that some patients in cluster 3 are actually from the general population, potentially unrecognized heart failure patients, but also that some patients from the TopCat and MEDIT trials, which were really, really strong on inclusion criteria, TopCat with certain problems, but these are randomized studies, have a lot of patients in this relatively healthy cluster. So in this final slide, we can see that machine learning can not only help us phenotype patients, and it can help us put various data sets together to extract knowledge from one data set and use it to learn, to extend this knowledge into another data set, potentially helping us choose better patients for clinical trials, or helping us understand why a certain patient has certain clinical development. So in conclusion, non-invasive imaging obviously is crucial for management of cardiac patients, and artificial intelligence can provide benefits through improved integration of data, improved patient phenotyping, and helping us assess patient risk. And if applied correctly, we can really expect that one of the main benefits of artificial intelligence can be through a new approach to patient, where we have more time to really focus on the things we need to focus and leave artificial intelligence to help us do the dirty work, the segmentations, the time-consuming things we have to do every day. And then the analysis is left to the clinician to really help save time and bring attention back to the patient. Thank you for your time, and I'll be happy to answer any questions if there are any.
Thank you, Professor Lunkaric, for the very interesting presentation. Any questions for the audience? I think here is a little bit tricky because our public here is from clinical cardiologists, and they are more involved in the clinical echo. But I think, yeah, Alex, you have some question?
Yes, please. And I think I'll probably follow up on your comments, Krasimira, because Philip, thank you for a beautiful presentation. I know I'm always fascinating when you and Bart's group give talks. My question as a clinician is what would you need if you have resources to implement this in an electronic health record system? Our issue from a clinician's part is mainly GDPR regulations in Europe, because you would probably need to draw data regarding date of birth, gender, some physical parameters, then add on the images. Do you think it's possible to integrate the images with all the clinical information that is available and then continuously update that knowledge?
I think that's one of the questions everybody is working on at the moment. And when you talk to, for example, GE, when you talk to Philips, actually, they're all developing ways to really connect all their systems into one. If you have, for example, GE software for echo analysis and GE software for MR analysis in the same hospital, you currently don't really have it connected. and now they're developing new software to integrate this data. But then it's still going to be a problem if you want to do machine learning analysis. And how we see it, how Barbin's group is actually working on at the moment, is that you do real-time machine learning on the Echo Station as a plugin to the software that is, for example, the GE EchoPack or the GE Echo devices, where you have a plugin, a software plugin, which can do the machine learning on the machine in real time, using some new methods which really require less computing power and less time. And then in that sense, you can avoid this cloud of data, which is actually really tricky to do. We've been doing it this way, but it's horrible. So we need to find a way to bypass.
So put the machine learning into the GE machine,
exactly.
avoiding using the whole clinical ecosystem, because that's obviously where all the regulation is happening.
Exactly, but also it will require that you input some information, which is not that much of a problem, since a lot of clinics actually do input the height, weight, gender, and maybe some more information. But this isn't such a revolutionary concept, actually, because nowadays when you use EchoPack, for example, from GE, you already have artificial intelligence embedded into the things we use every day. And I think people are not really aware of it. It's not going to happen. It's already there. So we're using these automated peak calculations. We're using automated speckle tracking already, which is sometimes working, sometimes not. We have the Doppler traces, which work actually quite fully. We have automated septal measurements and the personal long axis, and you have it today in the clinical workstations that we use every day. So artificial intelligence is already integrated into the hardware, but now the question is, can we move from these automated measurements towards phenotyping? And that's the tricky step, because with phenotyping, you go towards diagnosis, and if you have diagnosis, it's a lot more serious, and you have more regulations too.
In our clinical works system, so the pneumologists, they perform lung function testing. So they generate a whole lot of numbers and also traces of things, you know, and they generate a probability of diagnosis. So that's actually included under their report. Probability of obstructive lung disease is 60%, restrictive lung disease 40%, and it hasn't been an issue. So I guess if you just report a probability, it's not an issue. If you report a certain certitude of a diagnosis, it's not going to
I completely agree. I think like the first step will always be as a fail proof for the clinician. Like it's a software that helps you not miss things. It tells you, does this patient have elevated blood pressures? Does this patient have diastolic dysfunction? And then you say, yeah, no, that's a mistake. It doesn't. Or you say, oh, yes, maybe I missed this. I didn't see this. I think that's the best first step for this part of the development. I think that's the way to go.
Yeah, I agree.
Thank you, Philip. It's really great to see that you continue the work of the Professor Binis. I remember it a couple of years ago, his presentation about the hypertrophic phenotypes and the clusters of the models. So the deep learning and the machine learning is developing the artificial intelligence, which is a new generation from the faster and easier models for the analyzing of the risk of the patient groups. Except the different models that we have with aortic stenosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, and HFpEF, which is will be the next step? Congenital?
Well, that's kind of thank you for the question. I think that's on everybody's minds. How can we use this? And I think the good part of the whole machine learning thing is that if you have the echo function for every patient, you can do machine learning that we just presented. And if you have a patient output space where we saw hypertension, HCM, and being separated already using just our initial attempts here, you can put in other, actually here, they're here, and you don't know why they're separated, but you can find out, you can explore, and with enough data, you can build trust that the separation is actually sensible. So as an answer to the question, I think any cardiac disease where you can get a nice image of the heart, I mean, a typical image of the heart, you can basically do the machine learning that we're doing currently.
Thank you. Въпроси, колеги? There is no other questions. Thank you so much for both our lectures from Belgium and from I think you have moved from in Amsterdam.